Professor Miranovic is full professor and head of the Department of Pediatrics, Faculty of Medicine, University of Montenegro. How to deal with the grief of parents who have a dying patient?
Well, distinguished Professor Kolangos, dear colleagues, thank you for the opportunity to bring this topic with, together with all those posh and noble. My topic today is multidimensional. It is not only medical, it has some metaphysical meaning, some psychological, and just a few drops of religious, just a few drops. During the long period of humankind evolution, man started walking on two legs. He increased the brain size and complexity. He developed lactose tolerance, made a lot of steps from simple stone tools to modern technology. But there is something that stayed beyond the reach of evolution. It's mental suffering for a dying child. Maybe this is an evolutionary achievement after all, because maybe it's something that drives us to have offspring, to raise them unconditionally, and to be infinitely sad if we lose them, all with the aim of species survival. When, the life is the most precious gift given to man. When the child is born, parents are happy and have a lot of expectations. When the child is born healthy, 50% of patients, because of the changes of roles of patients, sometimes feel depressed and pessimistic. But after a while, that feeling disappears. But when they have a child with congenital heart disease, that feeling does not disappear. On contrary, it deepens. What makes children with congenital heart disease different? Their appearance, behavior and emotional development, cognitive development and learning, and medical condition. What frustrates parents of children with congenital heart diseases? Well, beside the fact that we have improved conservatively and surgical treatment of the children with congenital heart diseases are still the leading factor, the leading cause of death under the age of 1 year among children with congenital defects. On the other hand, the survival is expected outcome for the children with congenital heart defects, which somehow makes position of parents very difficult. They face problems of mental, emotional, social, and financial type. And yes, Professor Mark was right when he told yesterday that parents deal with that problems in different manner. And yes, he's right when he said that fathers are leaving more frequently family with a child with congenital heart defects. Those families are very specific. For example, for me as a pediatric cardiologist, it was very interesting that the level of a parental stress is not related to the severity of congenital heart defect. Example number one, My husband and I wanted to visit friends, went to the flower shop. Florist recognized me and told me, well, when you told me that my child have a congenital defect, you were my worst enemy in the world. But when you told me that my child doesn't have a congenital heart defect anymore, you were the person who I loved the most. So our everyday communication with the parents is in a wide range of emotions that we have to accept. Another situation is that in some studies, parental behavior was compared with psychiatric patients. That is example number 2. My younger colleague, pediatric cardiologist, was working a night shift, and she examined about 40 to 50 patients, singles out one girl with a mild gastrointestinal symptoms and admit her to the hospital. After 2 months, she received heart transplant. During those 2 months, mother was calling my younger colleague all the day and night long with a series of questions. She asked about the condition of her child, and having in mind that it is completely normal. Can you put the... when I saw her, can you put the voice? When I saw that my colleague is suffering, I sent her a little clip from Dr. House, where mother asked him after treating him like, very hard way, can we call you anytime? He answered no. I just wanted to remind my colleague that sometimes we have to set boundaries between privacy protection and professionalism. She didn't answer. She was completely trapped. What is the family that we in pediatric cardiology like? The families with elastic adjustment. It is a model which promotes resilient, flexible family that is rapidly moving through the process of adaptation and has a much better outcome. When the child is dying, parents may develop unusual coping skills to sustain themselves and their family. The most unusual, I will ask technical support. Can you put that video? Can you put that video, please? The most unusual example was a family coming with a big smile on their faces, both of them, and brought with them a dying child after 3 years of break of follow-up, which ended up after 12 hours in Belgrade in the operating theater because of the vegetations due to bacterial endocarditis. So it was really unusual. Big smile on their faces with a dying child. But when the child dies, all the coping skills and strategies fall into place. Bereavement and grief taken together are understood to be a normal and universal part of the natural healing process that enables individuals, families, and communities to live with the reality of loss while going on with living. It is especially hard when the child who dies is adolescent with stable characteristics and recognizable character. That's very hard, especially if the child is considered healthy and dies suddenly, as this 11-year-old boy who had unrecognized bicuspid aorta with bacterial endocarditis and low fever, wandering from one pediatrician to another for 3 months And when he finally came to our institution, he died after he was diagnosed, treated with antibiotics, and died after 5 days. It was really suddenly. The other example is 15-year-old boy on which obituary is written that he died suddenly, but he did not. It was a message to the public, because it is a stigma in Montenegro if someone died from congenital condition. He had an extreme Marfan syndrome and was followed up for 14 years, almost from his birth, and his parents knew everything about the life-threatening condition that he was passing through. Well, the process of conceiving, giving birth, and raising offspring is shared by virtually all living animals. But human experience of this process, however, adds many elements of psychological, social, and meaning constructions. The parent-child bond is not only particularly strong, it is also integral to the identity of many parents and children. Why parents react to the child's death in such intense manner? Because the love for the unique child who has died, the special intimacy and strength of the parent-child bond, unlike most other relationships, the connection with the parents' hopes and dreams for the future, and even immortality, and so on. Freud described the metaphor of amputation very eloquently, with deep personal introspection, when wrote a letter to his friend when his eldest daughter died. He described that as a vivid sense of missing a part of oneself on which you can get used to, but never will grow up again. What we as physicians sometimes do, sometimes we can unconsciously accept the myth, cultural myth, that we are omnipotent and omniscient. We also, in the era of modern technology and ethics of saving lives, sometimes have a delusion thinking that we can conquer death. In that situation, doctors take an idea and their fear of death, intellectualize it, and deals with it in omnipotent manner. But when the death of a patient is approaching, all the defenses are break. What are we facing in our everyday work? Well, demanding patient. If our demanding patient is not so much ill, it's not a problem. Medical staff will react appropriately. But if his illness is ultimately fatal, medical staff can react in mixed and confused, becomes inwardly hostile yet outwardly. Because of guilt, our reaction is inappropriate. Another problem which can happen to us in our everyday work is hostile parents' bereavement. When we say to our parents of our patients that their child has a fatal illness, they often go into anticipatory grieving, which is a very painful process, especially during the protest phase, where parents often direct their anger toward the medical staff or to the institution. doctors, not having in mind that it's a normal part of the process of healing, may react very defensively. Another thing that can happen to us is over-identifying with patient. Physician often identified with the patient, parents of a dying child. How this act in everyday's work? They can abandon their medical role and assume a more parental one. What to do in that situation? Some physicians may hide behind the professional facade, but it will be recognizable from the patients, and they will think that it is a product of aloofness and disinterest. Some of us become too involved with their patients and either lose professional objectivity or develop personal psychological problems. Now, when I am too old and too mature, I do not share information about my patients with my husband. He told me, no, I'm not part of that story. I gradually developed an observing ego, which helps me to become aware of these feelings and to deal with them in a proper way. The key word between patients and medical staff is anxiety. Anxiety is especially expressed when we have adolescents who suffer from a disease because of which he is going to die. Our medical staff is very young, and they can identify that patient with their brothers and sisters. In that situation, when they realize their eventual death and it becomes crystallized, acute anxiety appears. Acute anxiety is sometimes called existential anxiety, and it is precipitated by the realization that at one point we can no longer be. Existential anxiety is a message from past, from ancient times, but when there was an anxiety of fate and death, from Middle Age, where was anxiety of guilt and condemnation, and finally, anxiety of modern era of meaninglessness. Famous writers like Heidegger and Sartre send us a message that no one can seriously start living until he seriously have in mind, consider his mortality. Viktor Frankl sent us a message too. The appreciation of suffering makes our life meaningful. Finally, at the situation that we have with our adolescent patient, meaninglessness of life is particularly poignant when dealing with children or adolescents who have not fully experienced life. It makes us very sad. Finally, all our accomplishments, doings, bad and good decisions will not survive if we don't take seriously that the death is inevitable. A message to take away for the pediatric cardiologist from this session from me is do not consider your patients only by hemodynamics, anatomical, and pathological peculiarities, because you can be socially disadvantaged. You're in risk to be socially disadvantaged. You have to take care of your patients inside the complex puzzle of them and their family with all their weaknesses and strengths. Finally, we have to help them unconditionally But we have to preserve the clarity of our mind, so our decisions have to be timely, fair, and objective. Thank you for your attention.
Thank you very much, Professor Miranovic. We are out of time. Any comments or?
Thank you.
Thank you very much. Congratulations.
Very
And
interesting.
we moved on the next session.